Welcome to today's webinar of the National Colorectal Cancer Roundtable. Hello, everybody. My name is Kara Riemann, and I'm the Strategic Director for Evaluation and Research at the American Cancer Society. I'm also the lead evaluator for the Links of Care pilot project, and I will be your moderator on today's webinar. Thank you, everyone, for joining. We've had a lot of interest in this topic, and we appreciate your time and attendance. The purpose of today's webinar is to share what we've learned so far from our Links of Care pilot project. The Links of Care pilots, which have been funded by Walgreens Change Grants, the American Cancer Society, the Centers for Disease Control and Prevention, and the National Colorectal Cancer Roundtable, seek to improve colorectal cancer screening and follow-up care for uninsured and underinsured patients by strengthening relationships between community health centers and the surrounding medical neighborhood. The idea for the project began in 2012 when the Health Resources Services Administration began requiring federally qualified health centers to measure and report on colorectal cancer screening rates. FQHCs were concerned about securing follow-up care for patients who had an abnormal diagnosis, as follow-up services are often prohibitively expensive for low-income, uninsured patients. So to address this challenge, the NCCRT, ACS, and CDC implemented the Links of Care pilot program to promote collaboration between FQHCs who are serving low-income patients and specialty providers to secure diagnostic services. Goals were to increase timely access to specialists after an abnormal screening, implement evidence-based strategies to increase colorectal cancer screening rates, and to assess project implementation. So today we'll hear from leaders from each of the 3 Links of Care pilot sites who will provide you with a brief overview of their specific pilot site while also discussing implementation, partnerships, workflows, and lessons learned. We'll hear from Dr. Suzanne Lagarde, who's the Chief Executive Officer at Fairhaven Community Health Center of Connecticut, from Julia Williams, the Chief Nursing Officer at Beaufort Jasper Hampton Comprehensive Health Services of South Carolina, and then we'll hear from Chris Singer, the Chief Operating Officer at Westside Community Health Services of Minnesota. So I'd like to share a few housekeeping items before we get started. We are recording today's webinar. The replay and speaker slides will be shared with all of you within a few days. Please feel free to share with your colleagues that weren't able to join us today. Also, because of the large number of participants, all participants are muted on today's webinar. Having said that, we still want to make sure that you get what you need from the webinar, so we encourage you to ask questions by submitting them through the webinar Q&A function. We will have time for questions after the presentations, and we'll answer as many as we can. And we'll also be emailing around any responses to questions that we don't have time to get to. You can also email us specific questions after the webinar. And finally, we're always trying to improve our webinars, so we are asking for your help in evaluating the webinar. You will be receiving an email with a survey link. Please help us out by taking a few minutes to provide your feedback. We take this advice very seriously and are always trying to improve. So with that, I'd like to start by providing you with a brief background on the project and our initial findings from our ongoing evaluation. The opportunity involved providing 3 grants in the amount of $150,000 each over 30 months to 3 federally qualified health centers and partners, and to decrease colorectal cancer mortality rates with that goal. The 3 sites were selected on May 30th, 2014, and are currently still implementing the project through 2017. The grant funding is intended to stimulate collaboration among local partners and support development of the long-term structures and relationships needed to improve access to specialists in the community in the delivery of colorectal cancer screening. So each of the pilot sites received $150,000 for 30 months. $125,000 went to the FQHCs, primarily as compensation for reporting requirements, but also to support, to provide some staff support and resources. And $25,000 went to a partner applicant in the community. The NCCRT assisted pilot sites in conducting a community assessment as one of their initial activities, and the NCCRT and ACS also helped each of the pilot sites coordinate a stakeholders meeting to design a plan and improve care delivery. And also the NCCRT, ACS, and partners working together spurred involvement of additional physician leaders. Partnering communities also have been receiving technical assistance from ACS throughout the assessment and planning phase as needed. And they also receive coaching on high-performing models and other support throughout the implementation phase as needed. So as I mentioned, the primary goal was to increase timely access to specialists after a positive screening result. The secondary goal was to advance evidence-based strategies to increase colorectal cancer screening rates within the primary care systems themselves. This is a list of the pilot sites. There was one located in St. Paul, Minnesota, one in New Haven, Connecticut, and one in Port Royal, or what we call the Low Country in South Carolina. So we had 2 urban sites and 1 rural site. And you'll be hearing from each of these partners throughout the presentation. So part of our evaluation was looking at a couple key things that we wanted to understand a little bit better. One, how have F2HC partners implemented the LINKS project? How did they go about building external collaborations with GIs and hospitals? And also, how did they implement their internal system processes to implement a screening navigation program? We also were interested in understanding the role of the ACS staff in project implementation, and overall to understand what did we learn from this pilot that will help us not only sustain but to expand the length of care. So the evaluation involved conducting site visits over last summer to each of the pilot sites. We interviewed staff from the FQHCs, from the GI and hospital partners, and also ACS staff, and we're still in the process of analyzing that data. So I'm just going to provide some very high-level themes that we've been finding as part of the results of the evaluation. So in terms of building partnerships, some of the strategies that were reported to be successful were that the pilot sites identified GI champions who are committed to public health and social justice and recognize the importance of colon cancer screening. And identifying that at least one GI champion was really key for building those external collaborations. They also, in building those partnerships, emphasized the role of the screening navigator and the fact that the screening navigator would have the ability to decrease no-show rates and ensure the patients got to their appointments for colonoscopy and also were well prepped. And they also built on existing relationships that they had between staff of the FQHC and the hospital. In one instance, FQHC clinical staff sat on hospital committees, so they were able to build on those existing relationships. In another one of the sites, the CMO and hospital, FQHC CMO and hospital CMO already had a strong personal and professional relationship, so they were able to build on those as well. The role of the patient navigator was one of the key factors of this project that really ensured the ability to implement the project. The role of the navigator, you can see how many responsibilities and activities they were involved in. They provided education on FIT and colonoscopy. They referred for colonoscopy. They scheduled colonoscopies in some cases. They would provide reminders to the patients. They would ensure that the patients had access to their prep and had transportation to get to their appointments. They tracked results in the HR and tracking system. They would inform patients of the results. They'd follow up on no-shows. And they were also involved in referring to any needed follow-up or treatment. So you can see the extent of the activities of the patient navigator. And the role of ACS, we found that the reputation of ACS, not just ACS, but the NCCRT, really enhanced legitimacy, especially at the beginning of the project. Being able to bring these partners to the table and having key senior staff from ACS and NCCRT attend these stakeholder meetings was really important. And ACS really took an active role in partnership building. They were viewed by both GI hospital partners and the FQHCs as serving the role of an independent third party, and they could have separate conversations with the FQHCs and partners kind of behind the scenes to do any kind of problem solving or dealing with any kind of communication issues. And we also heard from our FQHC partners that ACS staff were important in providing support and reassurance, and they felt like because of ACS's involvement, they weren't out there fighting this alone, that they had a lot of support and resources to help them be able to implement the project. And as I mentioned too, ACS was very active in any kind of problem solving or communication, ensuring appropriate communication between the FQHCs and their partners. So the keys really to successful implementation on this project have been to start with the right partners, in particular ensuring that the partner leadership is at the table initially. So the decision makers, the folks who can say, yes, we will be involved in this, need to be at that initial meeting in order to provide the go-ahead for the rest of the organization. Really, the patient navigator, this role, I can't emphasize how important this role was. In all three of the sites, the navigator really took an active role in ensuring that the client got to where they needed to be, that they reduced no-show rates, that the patients were well prepped, and having that really gave confidence to the GIs and hospitals that these patients would show up for their appointments. The FQHCs also had very passionate staff and significant leadership involvement throughout the whole time of the project. They also were using data to demonstrate progress and to identify challenges and figure out where they needed to make any adjustments. And they also took time to celebrate successes. At this point, I am going to turn this over to Dr. Suzanne Lagarde, who is going to provide some information about her pilot site, the Fairhaven Community Health Center.
Thank you, Kara. I am fortunate to be at Fairhaven Community Health Center. We're in New Haven, Connecticut, and to just give you a little sense of who we are, we serve just over 18,000 patients annually, the vast majority of whom are Hispanic, the majority of whom are monolingual in Spanish, and we have a fair, despite the fact that Connecticut is an Medicaid expansion state, we still have a 25% uninsured rate. So these are the basic demographics of the clients who we serve. So our program was focused on colonoscopy first. We were very fortunate in that we were able to partner with members of the Department of Digestive Diseases at Yale University School of Medicine. We did use FIT testing for patients who either refused colonoscopy or who were deemed to be at too high risk for colonoscopy. The model used was open access, which means that the gastroenterologist saw the patient for the first time on the day of the procedure. All of the upfront work was done by a patient navigator and by the primary care provider. And as Kara said, I can't emphasize enough the importance of this what I call high-intensity patient navigation. I think it's a critical game changer in working with low-income patients and getting them to screening. Most of our funding through the Links to Care went to support a patient navigator salary and fringe. Because we are in a largely Hispanic community, we hired only from the community, so someone who's bilingual, who's passionate for the work. And the other big piece that I think is critically important is to create clear guidelines as to what the navigator has to do. So we've created a checklist and a series of guidelines, and we train the navigator also how to track the data and the outcomes. A little bit of a busy slide, but I think it's well worth reviewing because these are our guidelines for our navigator. Unlike some programs which will use a phone encounter, we have felt that compliance is better when face-to-face, so all of our patients get an appointment to meet face-to-face with the navigator. The navigator is trained herself or himself in different aspects of education around colon cancer and colon cancer screening, and is trained to train the patients about why this is so important, about risk, lifestyle risks that put them at increased risk for various kinds of cancers, especially colon. And in our population, there are a lot of urban myths about colonoscopy, and we try to dispel those. We schedule the procedure never more than 4 weeks in advance, and we try to make that within 2 weeks because we know the longer in advance, the greater the drop-off rate or the no-show rate. We confirm transportation, including knowing who that transporter will be and having their contact information. We review the bowel prep in the patient's native language and provide not only verbal but written instructions at an appropriate literacy level. We have the bowel preps here. We provide them to the patient, so it just minimizes that extra step. In Connecticut, Golightly is fully covered by Medicaid, so that's one of our common preps. We look at the navigator will review the medication list and will know which drugs may need further clarification from the primary care provider or a specialist, such as anticoagulants, diabetic meds, et cetera. And then the patient is told that we will contact them within a week before the scheduled appointment. And if we cannot contact them and make that contact, we will cancel that appointment. And that all goes to the whole issue of no-shows. We know that no-shows kill programs, and we take every step possible to minimize that risk. And then lastly, all patients are called the day before when they're presumably in the midst of their prep to literally be a cheering squad, encouraging them to continue and to complete the entire preparation. And this is a summary slide of 3 years of data. So in the 3 years since we engaged in the Links to Care program, there were just under 1,500 referrals, of which about 50% have been completed. You'll see that there's still a high pending number of 224, and that goes to one of our challenges that we identified fairly early on, which is the capacity of our partners at the Yale School of Medicine to perform all of our referrals. About a third of the patients never followed through. Well, they were not performed for a variety of reasons. Some were deemed too high risk, and they were given a fit. Some patients, the majority, despite our best efforts, just decided they did not want to proceed, and they were given a fit. And of the fit, about 70% of them were returned, and I should point out that we give that task to the navigator. We don't just hand a fit. The navigator pursues the patient to ensure or to maximize the likelihood that the fit will actually be returned. Of our results, they're fairly typical of what one sees in large screening programs. About a third of our patients had an adenoma. We actually detected 4 cancers, 3 of which were very early stage, 17 advanced lesions. And the things that I am very proud of is that we had a no-show rate of 2.9%, but this is something that we were very, very focused on, recognizing that no-shows really undermine programs. And similarly, a poor prep was encountered very infrequently, in 0.3% of those who ultimately underwent the procedure. For those of you on the phone who are in federally qualified health centers, you're very familiar with UDS metrics. These are metrics that we have to report on yearly. The colorectal cancer screening rate at Fairhaven in 2014 was at 43.6%. And you can see that through the years of the project, we've been gradually increasing. And our last 12 months of data from July 1st of 16 through June 30th of this year, we're up to 54.9%. We're still aiming for 80% by 2018. I don't know that we're going to make it, but we certainly are striving to continue to improve these numbers. Our partners at Yale were very interested in analyzing the cost effectiveness of the program. So this data that I'm presenting here comes from them. After 2 years, we had 3 cancers diagnosed. A cost analysis of those cancers revealed a savings of roughly $263,000, a savings of $36,000 from decreasing the no-show rate. But unfortunately, the low reimbursements from Medicaid and from the uninsured resulted still in an overall net loss of over $500,000. And the pie graph to the left reveals the payer mix of the patients who underwent colonoscopy screening. You can see that 56% were Medicaid and 9% were uninsured. So what are the lessons that we learned? Hands down, navigation makes this program. It is the key reason why there's such a low no-show rate, and that is critical to maintaining the commitment of your referring gastroenterologist. Unfortunately, the cost of navigation is still not reimbursed in this state. The data from the Yale University showed that this is still not cost effective. And the colonoscopy capacity of the participating gastroenterologist is a limiting factor, and we've learned that we can do no more than about 250 a year. Attempts to engage more GIs in private practice fail, and I can say that even with a tremendous amount of support and help from the American Cancer Society, we did achieve one private practice to work with us, but they have imposed a number of limitations, such as they won't see the uninsured, they don't want to see people who are monolingual in Spanish, so that obviously limits who we can refer to them. And what's been our response to these challenges in terms of our capacity limitations? Starting this year, we changed our program from colonoscopy as first line for everyone to a FIT testing for our average risk patients, and then colonoscopy for our high risk, most commonly patients with prior history of adenomas or first-degree family relatives with colon cancer. We continue to try to engage private practice gastroenterologists. This was dealt something of a blow in the past year because the state of Connecticut is having massive financial difficulties, and one of their efforts to make that better is they imposed a 6% tax on all ambulatory centers. So now the private GI docs are saying, you know, Medicaid pays so little, and now we have a 6% tax on top of that. We really can't do that. So it's given more ammunition to the reason why it's difficult to engage docs in private practice. In terms of sustainability, similarly, we think that transitioning to a FIT for an average risk population will help both in terms of making more colonoscopy slots available for those who are at higher risk and in terms of cost. And we are involved, we're part of a state pilot looking at value-based payments. Currently, colon cancer screening is not part of the quality metrics of that particular program. We're suggesting that they do that. And if this pilot materializes into something more permanent, it will provide a mechanism for some sort of advanced payments, which would help to sustain the navigator. So with that, that's my presentation. I'm going to turn this over to Julie in South Carolina, who's going to tell you about their program.
Thank you.
All right, Julie, we're on your first slide.
Thank you.
Speaker Julie Williams.
I'm Julie Williams. I'm the Chief Nursing Officer and Director of Quality Assurance here, and I was the coordinator for the LINCSA grant program for our community health center. Next slide. Our mission was to deliver comprehensive health services to socio and economically deprived residents of Beaufort, Jasper, and Hampton counties. We're one of 20 FQHCs in the rural low country of South Carolina. Beaufort County is about 923 square miles, of which 38 is water. There's no public transportation system, so you can imagine if a bridge is out, what kind of chaos we have here. Although Hilton Head, which is our next door neighbor, has affluent resorts, extreme poverty still exists in other areas. Isolated islands present unusual geographic and socioeconomic challenges here. Next slide. Our center represented the rural communities in this grant. Obviously, we had more limited hospitals and gastroenterologists to turn to for partnerships and collaboration. We chose to do the FIT to colonoscopy program at this time. We are still doing the occult blood testing and referring patients for colonoscopies with little compliance, as you will see later. Having worked on an earlier colorectal screening grant that assisted patients with free colonoscopies, but ended rather poorly, we're eager to proceed with this grant. We have seen how grateful our patients are to be able to receive the colonoscopies, so we believe that this would be an exciting venture for us. Next slide. The purpose of the LINCSA Care pilot was to stimulate collaboration among local partners and improve access to the GI specialist. The partnerships far exceeded our expectations, and I will discuss that later on, but we went into this somewhat skeptically. Our chief medical officer was the biggest naysayer and thought that we would not be able to succeed with building collaboratives within our medical community. There were few, if any, major collaboratives within the community at the time. Next, we wanted to tap into the rural communities where services are very limited and health disparities are high. We felt that offering the FIT test versus colonoscopies was a cost-effective means of capturing patients who just were not going to have the colonoscopies or did not have the monies to have the colonoscopies. Next slide. You will hear us talk about navigation, and so you have. I can't stress enough the role of the navigator for coordination, troubleshooting, and coaching patients through the systems. They're instrumental in ensuring a successful program. If patients were given a fit test and failed to send it in, she would call them, remind them. She could often be heard laughing with them as she pitched her lines and they responded to her. We actually have 2 navigators now, one for the uninsured and one for the insured patient population. They follow 2 different paths, with the uninsured moving through the FIT program and working with the Access Health of the Low Country Navigator, which we'll talk about later, to schedule colonoscopies. The other has to navigate through our hospital-owned Low Country Medical Center, and there are many challenges with this. Scheduling has become a nightmare, and we continue to struggle with this, and that struggle will probably persist. The last part of our pilot was the community assessments, and I think this was the most troublesome for us. The community participation was very difficult, and trying to get sufficient members in the community to complete the assessments was painful. Lastly, the stakeholders meetings were very poorly attended. We never had all the key players at the table at the same time, and had not been for our roundtable attending those conferences and showing their commitment to our success, I don't believe we would have obtained the early buy-in that we finally received from one of our strongest partners, Access Health of the Low Country. Next slide. Early on in the process, a great deal of planning was involved, as you would expect. Policies were written, standing orders done, research information gathered, and teaching instructions were put together for each of the center to have as reference materials. We found that our EHR was not conducive to tracking colorectal cancer screening data, so we developed our own tracking system. We approached a gastroenterologist in Hampton County who did procedures in his office to participate, and he agreed. Again, this was because we felt Beaufort medical community was not ready to engage in our process. When we were ready to begin screening, myself and the navigator went to each site and met with the staff. We did a staggered startup, and we only started with 4 out of our 8 centers. Next slide. Identification of patients was accomplished through reports run in our EHR for the appropriate age range and patients without colorectal screening. We developed a form letter which was sent to each individual telling them where they could go to get their screenings. This went extremely well with patients coming into the centers to get their kits. A word of caution might be to make sure you communicate to your front desk staff. We found patients showing up with letters, and our front desk staff was unaware of what we were doing in the back. Once the patients were given his fit kits, the nursing staff would log these on a shared blog, and from there our navigator took over and finished the process. The navigator received the results off a printer in the nursing office and contacted the patient of the results. If it was positive, she contacted our patient's Access Health to schedule the patient and coordinate navigation through the hospital system. Next slide. Should the patient require further surgery in oncology, the hospital navigator takes over and monitors the patient through the hospital system, and then to Kaiserling Cancer Center. We did have 3 patients that required a referral for cancer treatment. Next slide. This slide is a little busy as well, and I'm not going to spend a lot of time on it, but I did want to include it because it showed the complexity of the navigation systems. All of the parts of a puzzle that at any time can fall off the rail. Again, the navigator is vitally important to the success of a program, and fellow partners that can help you troubleshoot when things go awry, which they will, whether it's being a patient being billed, a scheduling meeting with the hospital schedulers to correct issues, and finally, keeping us abreast of changes within the hospital as to protocols. Next slide. You've heard me mention about key partners. All of our partners on the screen were vitally important to our program success. The National Colon Roundtable members who came and visited our community and lent their expertise, and by their presence demonstrated our community leaders the importance of commitment to this program. Another key partner was the American Cancer Society, in particular Vonda Evans, who provided assistance with reporting and other things, and certainly was a morale support for me when we met giant hurdles. Like when Dr. Montenegro, who was our first gastroenterologist, was told that he could no longer perform procedures in his office, and he had to go to the hospital to have all the colonoscopies done. Unfortunately, that was a for-profit hospital, and we were not able to bring them along as a partner. However, we had already done our ask with Beaufort Memorial Hospital and had been successful, so we were able to switch to the Access Health of Low Country and Beaufort Memorial. Access Health Country is a collaboration of organizations that provide health care to the low-income and uninsured adults. Debbie Slasix was their chairperson and attended all the stakeholder meetings. And early on, she took a very active role. She was so impressed with what we were doing, she asked me to speak to the group, and thus started a process that to this day I still can't believe. She laid the groundwork and scheduled the key players for our ask. She troubleshooted for us when the wheels fell off, like when the patients did receive bills for thousands of dollars. I think one of the most remarkable achievements of this grant is the partner involvement and how it is now a true community collaborative. By that, Access Health was impressed with what we achieved, and they applied for their own grant to start a FIT program for the other free clinics within our community. Those centers have been part of our shareholders meetings, were familiar with the process. So this grant has galvanized the community with those centers now doing FIT testing and expanding it even more now to include all the Beaufort Memorial providers. They're applying for a marketing and media grant to educate the community, and we will be working side by side with them. So what we've learned there is that you need to find your Access Health care within your community, those that work with the indigent and uninsured. And if you would, bring them on board early and develop that collaboration as seen in high-performing models. Next slide. So it comes time for the all-important ask. And at this time, within Beaufort County, there was only 2 remaining gastroenterologists. 4 others had retired or moved on. So that made our ask a little difficult. So we were in the parking lot before this meeting, and we were starting getting very cold feet. So we moved our ask down from our original 8 to 4. Well, we came time to do the ask, and everybody agreed with 4, so somebody smiling perked up and said, well, what about 6? And before we knew it, it was what about 8, and they agreed to do that. As it turns out, the gastroenterologist was so impressed with the results of the FIT testing program that he now fully supports the FIT colonoscopy program. He saw our chief medical officer in the hospital the other day and remarked that not one of the patients was referred that did not have an issue that he needed to take care of. Next slide. These partners were not originally on board at the start of the grant, but have since donated their time, and we thank them as well for their commitment. Next slide. This slide, along with the community partnerships and collaborations, is one of my favorite. I have been with this agency for over 20 years, and I've never seen our CRT screening rate beyond the 20 to 30%. Even though we tracked it over the time, and I spoke at all of our quality assurance meetings, and I ranted and raved, we just weren't able to move that percentile up. So when we hit 55% at the end of 2016, that was my 80% by 2018 moment. We're still going to go, and we're still going to try for that 80% by 2018, but I'm proud of how far we've been able to come. Certainly, if we could rectify the scheduling issues with colonoscopies that we have at the hospital-based center, it would certainly help us with that percentage. We've given out 3,210 FIT kits. We've got a 60% return rate. We've done 67 colonoscopies with 23 adenomas and 3 patients with cancer. Next slide. Real quickly, just a few other things. As I said, our return rate is 60%. And that, I caution everybody because we were told early on by our lab that if we did not keep our return rate up, that they would cease to provide the FIT test for us. So we're really proud that we've not dropped it below that mark. I was hoping to say that we still had 100% of patients adequately prepped. Unfortunately, we had one patient that, although they did the procedure, she's going to have to return because the prep was slightly inadequate. Another unsuspected consequence was the improvement in communication between our chief medical hospital and the chief medical hospital at the hospital. They did not have regular meetings. They were very random, but now they have regular meetings, and on topic is always the colorectal grant. Next slide. So lessons learned. They're pretty self-explanatory. Assistance at the national level and state level is extremely helpful. I alluded to communication, but communicate effectively and often so staff know the game plan and remind them of the CRC screening. Navigation is essential because there will be hurdles with like unexpected bills that your partners will need to address. Don't be afraid of your ask. We certainly were, but this program has generated and become a wonderful collaborative within our community. Our challenges right now, we have a new CEO at the hospital, and they're in the transition period, so we continue to work with our partners to sustain our program. We will continue to see if we can improve the scheduling of our insured patients since major difficulties still remain there. Although we have the full support of our CEO here at Beaufort Jasper to continue the program, we'll still look for funding opportunities when they come. We will partner with Access Healthcare of the Low Country to market and offer FIT testing to the entire community. In closing, develop those strong partners, build a strong navigation team, and don't give up on your community. We were very leery we would be successful, but my medical chief wanted me to share with you that, yes, she was the biggest naysayer, but now she is a believer. And with that, I'm going to pass it on to Chris.
All right, thank you, everyone. Appreciate being able to share Westside's story with you as well. And like the other 2 sites, many lessons learned and best practices that we've been able to develop within our system. Just as an overview, you can just see some of the key characteristics of Westside. We are an urban, federally qualified health center in St. Paul. We have the opportunity to have 17 sites across different areas of St. Paul. Many of those are remote sites that are embedded in homeless shelters and the junior and senior high school systems. And then we have 3 main sites to which we're doing primary care from. Like many of the others, and I'm sure many of you, despite being large, we still have a very high uninsured rate of between 35 to 40%. We are also an expanded Medicaid state for now anyway. And we continue just to have a high number of uninsured populations. We have about 70% of our populations that prefer a different language other than English. We serve many of the Latino populations, but also a strong Hmong population. So as we really embarked on this journey, one of the issues that we were having is that we were having very little screening being done at any point. Since many of our patients were uninsured and we didn't really have a place to send those patients if they had a positive IFOB, many of our providers weren't doing any IFOB screening. There was this mentality that colonoscopy was the preferred screening method, and since we didn't have options for our uninsured or underinsured populations, they just simply weren't being done. We really had no formal process for looking at our gap reports and identifying patients that were due for screening. We fortunately did have an EMR system that had a nice decision support foundation that was able to provide us some inkling as to who needed to be screened. But like I mentioned, there was just this tremendous need for follow-up care, and we really didn't have a way to provide it. As we embarked in Links to Care, we really started out by desiring a colonoscopy program, so trying to partner with other stakeholders in the community so that we would have more access to colonoscopies. And it didn't take us long to figure out that that just was not going to work. With a total population of 36,000 patients, and a population of about 8,000 patients that needed colorectal screening, even with donated colonoscopies, we knew we weren't going to get that many donated colonoscopies. And so we really very quickly made the change into becoming a primary fit site with follow-up colonoscopies for those fit tests that were positive or for those patients that were high risk or symptomatic. We had tremendous support from our chapter of American Cancer Society, and Poole and Roshan Padal were incredibly instrumental, as well as the Minnesota Department of Health, who have been working at the state level for a number of years prior to Links to Care to really develop these relationships. And so when it came time to do our stakeholder meeting, the ask was actually pretty easy. They came to the table knowing we were going to ask for donations and more than willing to give donations to us. We had 2 GI partners step up to the table to do this. I think Minnesota might be a little bit different than the other states in that in the Twin City area of St. Paul and Minneapolis, we do have several health systems that have gastroenterology care, but we have a very, very large gastroenterology practice of about 60 providers that provides gastroenterology care. And so it was one of these sites that was willing to donate services to Westside, and of course we were grateful for that. During the stakeholder meeting, we had a commitment of 12 donated colonoscopies from the larger site and 2 a month from the smaller site. The good news here is that the large site does not count. They are more than willing to give us as many donated colonoscopies as we need. And we really have worked with them as one of our primary referral partners so that they're getting our uninsured patient populations, but they're also getting our insured populations for those colonoscopies that are needed. I think this ongoing partnership has just been really important. We have regular conversations with them and really talk through what's working with the partnership and what's not working with those partnerships. And so all of that has just been really instrumental in expanding our program. So like I mentioned earlier, you know, we really did need to make several workflow changes. One, of course, was going to a primary IFOB campaign. The provider education that happened was really important. Dorado Brooks was fortunately willing to provide a webinar to our provider groups, and we have follow-up conversations in which he was the one that was able to convince them that colonoscopies were no longer the first line of screening and that there were other options and that those options were very effective for screening patients. And so that was really instrumental in really changing the thought that the provider had in how can I get this large group of patients screened. The patient navigator, incredibly important. We actually, through a foundational grant, are able to secure 2 patient navigators now in our system due to our large patient population. And they have some very detailed workflows that they go through to ensure that we are able to screen as many patients as we're able to. We certainly maintain a patient registry. They're doing all of those patient contacts. They're really walking alongside that patient throughout the entire process, providing that education about the IFOB. If the patient does require a colonoscopy, really walking alongside them in the prep and getting them the resources that they need to be able to have the test. So this is, of course, too small for you to read, but this is a workflow that has actually been changed a few times. As new resources become available, we adapt with it. Minnesota was had an advantage enough to be one of the states that the CDC funded for stage scope so that patients with a positive IFOB who are 50 to 64 are able to have a CDC-funded colonoscopy, and then they take that patient on for the follow-up treatment. So we now have a very detailed workflow on which, colonoscopies are going to go through the donated route and which are going to go through the CDC route. And so it's been a great strategy to reduce the number that we've had to push through the donation route and preserve some of our partnership for other patients that might need it. And be able to use those funds. Of course, we don't know how long that funding will last, but we're happy to take advantage of that. But fortunately, we've been able to work with our state health department and our navigators so that they are able to really handle that entire workflow. So, it took Westside probably a good year and a half. The first pilot project was actually 18 months long, and it felt like it took us almost that full 18 months to actually get the project going, to have that stakeholder meeting, to set up all of those partnerships. But since that time, we've just been really able to further expand on those core strategies that are leading to improvement and have been able to sustain that improvement over time. As of June 2017, we are at 62% screening rate for our patients. The one thing that I just wanted to mention, and I'm somewhat guessing that many of you are serving multiple patient populations, and one thing that we're really trying to do is really look at our data via as many patient disparity characteristics as we can. And we're really finding that patients who have a Latino ethnicity approach colorectal screening very differently than our Hmong patients do. And we have a number in our Hmong population who have had positive IFOBs that are very reluctant to have that colonoscopy. So it's been very important for us to really look at some of those additional data points to really ensure that our patients are getting the care that they need. I don't want to get into the weeds too much with our polyp data, but it's been very interesting data for us to pull out. We found that 95% of our colonoscopies had some kind of polyps. While many of those were benign, we certainly had almost 700 polyps that were not benign and certainly needed some follow-up. We also learned that we had a very much an unscreened population. You can see that we had 12 to 15% colorectal screening rate when we started. And it really showed as we started screening patients that had never been screened before. And so through this project, we have had a staggering 32 cancers. Fortunately, we have only had 4 of those be advanced stage cancers, but still just a very large number through an unscreened population. So just a few lessons learned as I close up. Certainly, we've moved to IFOD being offered first. The one thing I wanted to give some credit to is our lab services within our organization is all in-house, and they do the IFOB education along with our patient navigators. But we have a 98% return rate on those IFOB kits, which is incredible. They are very persistent and consistent in their workflow, and they are able to really work with patients to get those kits returned. Certainly, we'll continue to work with our partners through the colonoscopy program and just continue to have very positive relationships there. We have had a few patient incentives that we offered, and I know for some populations they don't work well. For our population, they work very well. That $10 or $20 gift card for our underserved populations often means some extra groceries that they can have, and so it really is an effective way to engage patients to come in to get their iFit. So just on what's next, we certainly want to continue to expand what we're doing. We're at 62%. We aren't yet at 80%. Our patient navigators are very engaged in our goals. They have put together stretch goals beyond what I thought we could do, and they've met them each year. So just very, very delighted to have such a great team of people working on this together. We have expanded this to an additional smaller FQHC in St. Paul who's also doing similar work to what we're doing. We would like to continue to spread that. Our GI partners are wanting to spread this. They, as a community need, they feel very good about what they're doing and feel like they have the capacity to be able to do that. So with that, I will close, and I'll turn it back to Kara.
Okay, great. Thank you. That was wonderful. We have some time for some questions, so I'm going to try to get through some of these. One question that just came in, which I think will be of interest to many folks, did anyone try and facilitate any of their uninsured to find insurance coverage? Would not that decrease the number of donated colonoscopies needed? I know here in New York State we have navigators that do nothing but assist people with insurance. So have any of your navigators been working with patients to get them insurance if they're uninsured?
Yeah, I can start. This is Chris from Westside, and absolutely, we also have patient navigators or MNsure navigators to help bring them on to the plan. The issue is that so many patients are uninsurable, and because of either their residency status, but there are still a lot of patients that just are not eligible for the ACA program.
Sue or Julia, any input there?
This is Sue. That's exactly the case in that our 25% uninsured, the vast majority of them are uninsurable due to their immigration status.
Okay. Julia?
And we did not have the navigator involved in that process. We do have patient financial counselors who assist the patients that are eligible to get insurance to assist them with the paperwork and whatnot to try to get them done. But the person did not get involved with that.
Okay. And then there was a question for Dr. Lagarde, but I suspect this would be for other folks. Were your patient navigators medical assistants, CNAs, or non-clinical, and what were their credentials? So I guess, Sue, we can start with you since that was directed at right after.
So we've actually had 3 medical assistants since this started. Patient navigators since we started. 2 of the 3 were medical assistants, but our current one was not. And simply, we trained her. We found that the most important characteristic of a navigator is a real passion to help and that they are from the community and that they have a real passion to help their community, and that they, have reasonable communication skills. So although 2 of our 3 were medical assistants, I don't think that that's a necessary requirement.
Any other folks about your credentials that you look for in your patient navigators?
Yeah, this is Chris. We were fortunate to have our first patient navigator still staffed in the same position, and she's just very passionate about that. She did have a medical assistant background and had actually done a lot of referrals coordination as well, and so she fit very well into that. Our second one is a community health worker, and so I do think it has been nice for them to have some exposure to some of the workflows that the staff that the patients are facing, so that they can help them navigate through it. But I agree, it's just so important for them to come from the community and be able to engage. I guess the other piece that I wanted to put in, just because of our patient populations we served, very important for those staff to be native to the cultures and bilingual. We actually have one of our navigators who is trilingual, who can speak both Spanish and Hmong, which of course works very well for our patient populations, but that ability to engage at a cultural piece was very important.
Julia, any input there?
My first navigator actually was a registered nurse. She was my nursing supervisor, and I really felt that I needed her to kind of pull the wagon and set the stage. And then my second one was a medical office assistant.
Okay. Okay, another question for these health centers. What percentage of your patient population that you're screening is homeless, and how do you help these patients navigate screening?
So Westside has a Health Care for the Homeless program as part of our FQHC funding. And so we certainly have patients that are visiting those shelters, and then we also have just some patients that visit our normal clinics that have a homeless status. So I would just say that our patient navigators work with that population very similarly to how they work with our other populations. We certainly partner with our social workers and others on how do we engage those patients, because sometimes they're a little bit more difficult to reach. We have to grab them when they come in for the clinic visit, and we can't rely as much. One thing that we have done is using respite beds for the prep period if they are having a colonoscopy, but the FITs certainly have been more successful, as there just are, of course, some difficulties with doing prep for a colonoscopy, but it can be done.
Okay. Anybody else would care to respond?
This is Mary. I'll dive in because we have heard of one really interesting example outside of these 3 pilots in which our friends in Florida, led by Dr. Belma Andrick, launched a Poop on Demand program in which they actually have a bathroom in the FQHC designated to screening, and the staff completely embraced it, and they found that it was a great way to increase their screening rates and help those who are more transient and for whom getting a test back is a lot more challenging.
Mary, while we're on here, this might be a question for you. In 2009, the American College of Gastroenterology published a guideline for FIT and state that guaiac testing should not be used. Do you know of any efforts to educate primary care physicians about this?
So we are working on an updated education brochure about FIT testing and trying to bust some of the myths. That should be out very soon. I will say I don't believe all of the guidelines have completely moved away from high-sensitivity guaiac testing. I have heard experts like Mike Potter, say that while FIT is ideal, there are some centers who, for cost reasons, still need to use high-sensitivity guaiac. So I think ideally we do move to FIT. If for financial reasons, a clinic is still sticking with guaiac, as long as it's high sensitivity, there may be scenarios where that's appropriate. Sue, do you have a comment there?
Sorry, can you just repeat that, Mary?
Oh, I was. That's okay. We can move on.
Okay.
But I will send out to the list an update on our education materials on that, and hopefully when they'll be coming out, because it is an important point.
Great. Well, I think we're just about out of time. It's just turning to 2 o'clock. So I'd like to really thank everybody. This has been a great presentation. Thank you to the presenters, the staff at the pilot sites, the GI practices, the hospitals, our local ACS staff, NCCRT. There have been so many people involved in this project who have really helped a lot. Dorado Brooks, Lynn Butterly and Jim Hotz and Jason Beers from NCCRT really got this project really moving at the beginning. So we hope you'll join us for the NCCRT's next webinar on September 26th, in which we'll share an update on the progress of the 80% by 28 initiative. And as always, for more information, you can email nccrt@cancer.org. And again, we'll be sending a follow-up email and collecting some of these additional questions and providing some responses. Thank you all for joining today. Have a wonderful afternoon.